Good morning. The hearing will come to order. Today's hearing will focus on seniors and people with disabilities who depend on both Medicare and Medicaid in their lifeline, or as their lifeline, I should say. Over 12 million Americans are eligible for both Medicare and Medicaid, including almost 500,000 in Pennsylvania. These Americans are expected to know which services Medicare covers, which services Medicaid covers, and which services aren't covered at all. They might have one insurance card for their primary care doctor, one for their behavioral health, and one for prescription drugs, and the list goes on and on. They might have a doctor who takes their Medicare insurance, but not their Medicaid insurance. Not only is this confusing and frustrating, it creates unnecessary hurdles for people trying to get the care that they need. All Americans deserve a healthcare system that they can actually use, not one rife with stumbling blocks. We'll hear today from Jane Doyle from northeastern Pennsylvania, not far from where I live. She lives in Monroe County in the northeastern corner of our state. Jane will share her harrowing story of navigating the complexity of these benefits, not only for herself, but also as a caregiver for her mother. She'll also describe how she lives in fear that her doctors, whom she trusts to keep her healthy, will no longer take her coverage. We'll also hear from Dennis Heaphy about his coverage that combines Medicare and Medicaid and how that lets him remain independent. But it was quite a road to get there, to get to that independence. Certainly there's work to be done. Jane's experience and Dennis's story make that very clear. I'm grateful that our ranking member, Senator Scott, and I agree on this point. Today we're introducing the PACE Expanded Act. This bill will reduce administrative barriers that prevent the development and expansion of PACE programs. In Pennsylvania, we call them LIFE programs, but in most of the country, they go by that name, PACE. These programs enable people with Medicare and Medicaid to receive all their benefits through a single organization, providing primary care, long-term care, and more in one place. PACE also enables people with a high level of need to stay in the community rather than receiving care in a nursing home if that is their preference. Indeed, this is the preference for the majority of older adults as well as people with disabilities. So that's why I'm committed to expanding access to home and community-based services. Last year, the Senate passed the American Rescue Plan, which included $12.7 billion in emergency funding for states for these services, these home and community-based services. States are using these resources to help more seniors and people with disabilities access care and to pay the heroic home care workers the hazard pay and the bonuses that they deserve. So this investment in the rescue plan of $12.7 billion was a good first step, but we need to do more and invest more to ensure people with disabilities and seniors can receive care in their homes. That's why I led 40 Democratic senators in introducing the Better Care, Better Jobs Act last year. That's Senate Bill 2210. This bill would make a permanent investment in home and community-based services. It would help states provide better care for seniors, people with disabilities, and their families, and it would ensure there is a strong and supported workforce to provide those services. It would lead, ultimately, to better care. These are just a few of the many issues faced by people that have to navigate both Medicare and Medicaid. We'll hear from several witnesses today who will highlight how we can continue to improve care for all of these Americans. Now I'll turn to Ranking Member Scott.
Thank you, Mr. Chairman, for working together on the PACE Expanded Act. Certainly, it is good for the country to see a bipartisan coalition working on behalf of the country, not on behalf of Democrats or Republicans, but on behalf of Americans. And one of the things I enjoy and appreciate about this committee is that we put seniors first, and not red ones or blue ones, black ones or white ones, just seniors. And that should be a mission for our nation and for all of those of us in elected offices, certainly to follow the example that you are leading by. So I really appreciate your work on the PACE Expanded Act, and the one-stop shopping concept is something that is really important when you have so many layers of complexity in your life as you age. If we can eliminate any of it, it helps all of it become more digestible and easier to handle for the seniors. So thank you very much for your hard work on that issue. One of the reasons why this legislation is so important is because we have nearly 12 million Americans and 150,000 South Carolinians who are dual eligible. They are eligible for both Medicaid and Medicare. And if you can imagine, as you had described, seniors with chronic conditions having multiple caregivers, multiple places to go. And if you think about Medicare, a national program run from the federal government, Medicaid, essentially a federal program, but run from the state government. And so getting those two to work together is not as easy as it should be. Anything that we can do in the direction of making that happen is going to be in the best interest of the seniors across this nation, and certainly the seniors in South Carolina that I know and love so much. I will say that the Biden administration needs to consistently and continuously working on making sure that those agencies that serve our seniors, like the Social Security Agency, is open. I am thankful to see that after 15 of my colleagues and I wrote a letter to President Biden asking for field offices to reopen, that we're at least seeing the move in the direction of telework for those agencies. I think it's really important for us to have an opportunity to have our seniors have the place to go, rather virtually or in person, when the pandemic subsides, for them to find the help they need from the agencies that they desperately want it. One of the focuses we have during this hearing, of course, is trying to figure out this jigsaw puzzle for the dual eligibles. And I'll say that the issues are quite challenging in many ways. And as opposed to thinking about how to explain it, I just thought I would use examples of two folks who are dual eligible in South Carolina who have benefited from having caregivers and care managers, case managers, who understand and appreciate the complexity of the situation. We have in South Carolina a program known as Healthy Connections Prime that allows for 3 providers, Molina, Centene, and AmeriHealth, to serve about 15,000 people over 44 counties to help that dual eligible concept become a little easier. Since the program started in 2015, we have seen improvements throughout the state. One member of the program was living in his car, homeless. His care manager noticed the signs that something was not going well. The care manager educated the young man about the plan benefits that assisted him and helped him find glasses, a place to stay, hearing aids, and dental work. Another Molina member from Florence, South Carolina, had been gradually declining over the past several months. His daughter, who also serves as his caregiver, noticed he was having more and more difficulty even with his walker and needed more support. His care coordinator worked with his daughter and the gentleman's doctor on the needs, and soon thereafter, a wheelchair was ordered, covered, and delivered. The member and the daughter reported that they were relieved and felt much safer at home, and they were able to get their appointments scheduled because of the support being provided. To help states further improve coverage, I have introduced legislation to provide further assistance to state Medicaid agencies to help integrate coverage. We created a $100 million grant for states to improve care coordination for their dually eligible population. States can use the funds to hire personnel that have experience with the Medicare program or train existing personnel or help beneficiaries with the enrollment process. Initial studies have shown that integrated care improves health outcomes such as decreased rates of hospitalization and readmissions. I look forward to hearing from our witnesses about what else we can do as Congress members senators to improve the lives of our dual-eligible population.
Thank you, Ranking Member Scott. Before we move to our witnesses for introduction, I want to note that we've been joined by Senator Collins, former chair of this committee, and Senator Rick Scott, who was here earlier. We're going to have senators, as folks might know, moving in and out because of a busy day of other hearings and engagements, but we'll go as people arrive, and grateful to have everyone with us today. Let me start with our first witness, Dr. Jose Figueroa. Dr. Figueroa is an assistant professor of health policy and management at Harvard University's School of Public Health. Dr. Figueroa's research focuses on understanding the drivers of healthcare spending and poor clinical outcomes among older at-risk populations with complex medical needs. He's also a practicing hospital medicine physician at Brigham and Women's Hospital in Boston, where he provides care to many Americans with Medicare and Medicaid. I want to thank Dr. Figueroa for being with us today to share his expertise with the committee. For a second witness, I'll turn to Ranking Member Scott.
Thank you, Mr. Chairman. I am pleased to welcome Eunice Medina. Eunice is a new South Carolinian, but someone who has a deep background and understanding of this critical issue. Eunice serves as the Chief of Staff and Deputy Director of Programs for the South Carolina Health and Human Services. The State Department of HHS is the agency responsible for running our state's Medicaid program, which provides health coverage to more than 1 million South Carolinians. The department also operates the Healthy Connections Prime program, which coordinates care for South Carolinians who are dually eligible. Ms. Medina's testimony today comes from her more than 18 years of experience working on this issue in both South Carolina and Florida, where she recently moved from. She has dedicated her career to working on behalf of older Americans and Americans with disabilities, those who are our most vulnerable and who need this assistance the most. Ms. Medina is one of the thousands of public servants who work every single day to make the lives of South Carolinians better. Welcome to this hearing, and welcome to South Carolina.
Thank you, Ranking Member Scott. Next, I will introduce Dennis Heaphy. Dennis is a health justice advocate and researcher at the Massachusetts Disability Policy Consortium. Dennis is also a commissioner on the Medicaid and CHIP Payment and Access Commission, known as MACPAC, M-A-C-P-A-C, the nonpartisan body that provides expert recommendations to Congress on ways to improve the Medicaid program. Mr. Heaphy also happens to have both Medicare and Medicaid. He's on the front lines helping states create programs that serve the needs of people with Medicaid by meeting them where they are. Thank you, Mr. Heaphy, for being with us today and sharing your expertise with the committee. Our fourth and final witness is Ms. Jane Doyle from Bartonsville, Pennsylvania, in Monroe County, as I mentioned in my opening statement. Jane has 2 children and 3 grandchildren. While they don't live close by, she's able to connect with them through daily phone calls. Jane describes herself as, quote, an artist at heart, unquote, and loves to paint. Jane happens to receive Medicare and Medicaid because of multiple sclerosis. She also helps care for her mother, who has Medicare and Medicaid as well. Thank you, Jane, for being with us today and sharing your personal story with the committee. So we'll turn next to our witness statements, and we'll start with Dr. Figueroa. Dr. Figueroa, you may begin.
Thank you, Chairman Casey, Ranking Member Scott, and honorable members of the committee. Thank you for the opportunity to testify today. My name is Jose Figueroa, and I'm an assistant professor of health policy and medicine at Harvard University. I'm also a practicing physician in hospital medicine at the Brigham and Women's Hospital, where I take care of critically ill hospitalized patients. For my research, I focus on how best to improve the quality of care delivered to the sickest and most vulnerable patients in our country, including the dual eligible population, which are those, as mentioned, who qualify for both the Medicare and the Medicaid program. As a physician and a researcher, I can attest to the fact that navigating our healthcare system is inherently complex for anyone. These challenges, however, are far more difficult for the 12.3 million dual eligible patients living with disability, with serious mental illness, with frailty, with multiple chronic conditions, and importantly, living in poverty. Because of these vulnerabilities, dual eligible people are much more likely to require hospital care, nursing home care, long-term care, home-based care, behavioral health, and unfortunately at increased risk for experiencing poor health outcomes. A great failure of our healthcare system is that so much of dual eligible patients' time is lost navigating the complex and confusing rules and regulations of two programs, which they must do in order to ensure they get the care they need. This is valuable time that they could instead be spending at home with their family and with their friends. And as a physician, one of the most frustrating realities for caring of dual eligible patients is our inability to help them effectively throughout this process. Countless hours are spent by clinicians, care coordinators, social workers, trying to determine what should be the safest discharge plan for our patients, while at the same time trying to coordinate their care across multiple different providers, across multiple different clinics. This often results in prolonged hospital stays and deconditioning of our patients while they wait. As stewards of our healthcare system, we have an obligation to deliver better care for dual eligible people. One important way of doing so is by promoting care models that offer true integration between both the Medicare and the Medicaid programs, financially and clinically across the entire care continuum. Integrated programs, when done right, have the potential to improve the efficiency, the affordability, and the quality of care that dual eligible patients receive. Today, there are three major types of fully integrated care models. They include, as mentioned, the Program of All-Inclusive Care for the Elderly, known as the PACE program, Medicare Advantage Dual Eligible Special Needs Plans, or the DSNPs, and state-level Medicare and Medicaid plans, or MMPs, under the CMS Financial Alignment Initiative. In my submitted testimony, I've outlined what the experience has been with these programs to date. The big takeaway is that while we have limited and at times mixed evidence on the success of these programs, there are some reassuringly positive signals that suggest integrated care, when done right, can improve the quality and the efficiency delivered to dual patients. And with more time and experience, we expect these programs to get better. However, to date, only 1 in 10 duals are enrolled in an integrated care model, and nearly 50% of dual eligible patients across our country don't even have access to one. In my written testimony, I highlight recommendations of how we can make integrated care for duals better. For example, Congress should consider policy options that help states adopt and expand integrated care models, especially in the 14 states that currently do not have one program. In some states, clear guidance, technical assistance, and financial support may be necessary. Integrated models must also offer meaningfully better value than the status quo and should cover all services patients need, from primary care, acute care, to long-term care and behavioral health services. The enrollment process into integrated care models must also be easy. Patients need adequate, unbiased support to ensure that they make an informed decision about what program is best to meet their unique needs and preferences. Finally, we need better transparency on performance, better and timelier data, and we need to develop better quality measures that capture what truly matters to patients. If and when we do this, we can ensure high quality and affordable care for the millions of people who are dually enrolled in the Medicare and Medicaid program across our country. Thank you for your time.
Doctor, thank you very much. Next, we'll turn to Ms. Medina. You may begin.
Good morning. Thank you, Chairman Casey, Ranking Member Scott, and members of the committee for the opportunity to participate in today's discussion. As stated, my name is Eunice Medina, and I currently serve as Chief of Staff and Deputy Director of Programs at the South Carolina Department of Health and Human Services. Prior to joining South Carolina's Medicaid agency, I spent 17 years working with Florida's Medicaid population in various capacities. I spent more than a decade of my career working with seniors through the Florida Department of Elder Affairs, where I manage multiple home and community-based waiver programs. In 2013, I assisted the Medicaid agency in transitioning those Medicaid beneficiaries into what is now known as Florida's statewide Medicaid managed care program. The following year, I joined the Florida Medicaid agency, where I worked to ensure health plans offering long-term care services were doing so in accordance to state and federal requirements. I later ended up overseeing their 15 health and 3 dental plans serving approximately 3.5 million beneficiaries. In June 2021, I joined South Carolina's Medicaid agency and have spent much of my first year analyzing how to best help the state by evaluating its Medicaid program and assisting the agency in developing a plan to improve quality of care and cost efficiency. South Carolina's population that is eligible for both Medicare and Medicaid, otherwise known as its dual population, have multiple options for receiving services. According to December 2021 data, there are over 168,000 dual eligible beneficiaries. Within that total, over 59,000 are enrolled in our dual special needs plans. 15,000 or so are enrolled in our state's Financial Alignment Initiative program, our dual demonstration program. And over 22,000 are enrolled in one of our 4 fee-for-service home and community-based waiver programs, which serve the disabled over the age of 18 or the elderly. This group may include beneficiaries with a corresponding Medicare Advantage, dual special needs plan, or fee-for-service Medicare. In 2015, our state chose to participate in the federal dual demonstration program to evaluate opportunities for integrated care for seniors. Unlike other states, South Carolina chose to start off the program with a focus on those 65 years of age and older. This month marks our 7th year anniversary since implementing this program, and I'm happy to spend our anniversary discussing some lessons learned. We have found that in cases where a beneficiary didn't need home and community-based services, they typically utilize 3 services that Medicare only covers a limited amount of: home health, durable medical equipment, and behavioral health. Access to these services through our dual demonstration program has delayed the need for more costly home and community-based services. Another lesson was the importance of care coordination at the individual beneficiary level and the importance of fully assessing beneficiary needs. We have a big decision to make as a state in deciding whether we want to take advantage of the alternative offered by the proposed rule that CMS issued on January 7, 2022, or explore other options. One reason to explore an option other than what is available through the dual demonstration or the recently released CMS proposed rule is the fact that Medicaid waiver programs are made up of more than just duals. When states are looking to integrate care, they may also need to consider the capacity of their Medicaid agency to manage the programs they have already committed to, which may include individuals that are eligible for full benefits under Medicaid, meet the nursing facility level care, but are not eligible for Medicare. This is the approach that Florida took. Florida consolidated more than 10 waiver programs that served its Medicaid home and community-based service programs and nursing facility population over a 5-year period. Through this model, Florida currently serves more than 100,000 beneficiaries through 7 comprehensive health plans, meaning that if someone is enrolled in one of these plans, they could receive both Medicaid medical and long-term care services. When possible, the Medicaid enrollment process considered whether a beneficiary had a Medicare product with a corresponding Medicaid plan. Streamlining programs and focusing efforts and funding on an integrated program can help avoid confusion and administrative burden among dual beneficiaries and providers. Even still, Florida's model presents opportunities to further coordinate care and information, chief among them being the integration of Medicare data. In conclusion, I truly believe each state faces its own challenges. For our state, we'll be looking for solutions that continue to allow flexibility in how to design our programs, access to Medicare data, opportunities to align processes across all Medicare and Medicaid products, and time to responsibly shift to a model that embraces these flexibilities. Furthermore, resources that would allow states to strengthen their agency to support these massive internal and external changes would be most welcome. Again, thank you for allowing me to participate in today's discussion on a topic I truly am passionate about and a population I have dedicated my career to serving.
Ms. Medina, thank you for your opening statement. And we'll turn next to Mr. Heaphy. You may begin. Mr. Heaphy, I think you might be muted.
Apologies.
Great, thank you.
Chairman Casey, Ranking Member Scott, members of the Senate Special Committee on Aging, thank you for the opportunity to testify about my experience as a dually eligible in an integrated plan. To start, I want to give special thanks to Senator Casey for his support of the disability community and his leadership on the COVID HCBS Relief Act. And Senator Scott, several of my family members have moved to South Carolina and love the state. I'm here to speak to you from the perspective of a disability advocate and member of OneCare integrated model in Massachusetts. OneCare was established to improve the health and wellness of persons 21 to 64 with Medicaid and Medicare by better aligning both funding sources in a single health plan. OneCare was designed to place increased weight on home and community-based services and diversionary behavioral health services and substance use disorder services, emphasizing independent living and recovery. I became a member of OneCare when it began in 2013 out of fear of losing my independence and my health in the fee-for-service system and or in an algorithm-driven, short-term, medically focused plan. I believe in the potential of integrated care and serve as chair of the Massachusetts Consumer-led OneCare Implementation Council, which is comprised of many stakeholders, but largely consumer and the consumers and our family members, working in partnership with the state to ensure OneCare meets enrollees' needs. Truly whole person-centered care meets the person's medical, LTSS, recovery, and other needs, helping the person to live in a meaningful life in the community. In my case, it means ensuring I have the home and community-based services I need, including personal care attendant services, durable medical equipment, including wheelchairs, assistive technology, medical supplies. It means having a care plan I've created with my care team and a direct line of communication with my nurse practitioner or physician assistant who can respond directly to my needs to reduce my chances of having to go to the emergency department or being hospitalized. I have experienced integrated care at its best. I had truly home-based care with my nurse practitioner coming to my home regularly. She's taught my personal care attendants, my PCAs, who helped me with my activities of daily living, how to do wound care, catheter changes, and more. When I developed a bone infection that required surgery, many hospitalizations, and over a year of recovery, rather than going into a skilled nursing facility rehab, my care team supported my decision to do recovery at home. My care team provided more training to my personal care attendants and increased their number of hours. Acupuncture was provided weekly to reduce pain and control my spasticity. My autoimmune specialist, even though an out-of-network provider, was regularly consulted. I received a ceiling lift to transfer me from my bed to my wheelchair, alternating air mattress, upgraded wheelchair and seating system, and more. Most health plans do not provide people like me these types of services or care. Thankfully, I usually don't need intensive services. What I need most are home and community-based services and supports developed in a care planning process with people I know and trust. Frustratingly, even though designed to be fully integrated, a whole person plan, OneCare seems to be moving away from the original model. I went to the emergency department for the first time in years because I could not reach a medical person at my plan, but instead could only get to the after-hours answering service. Not knowing what to do, I drove my wheel to the hospital a mile up the road. If I had been able to reach someone with medical knowledge, I would have not have gone to the emergency department. Other OneCare members are also identifying barriers to care, including lack of a care plan or trusted care partner and reduced access to services. The state is taking these concerns seriously and working with the Implementation Council, disability advocates, and the One Care plans themselves to address what appears to be a departure by the plans from the original intent of the model. I'm confident that because of the relationship between consumers and the state, we will be heard and we can make change. Not every state is like Massachusetts, but every state needs consumer voice to succeed in developing an integrated care system. Thank you again for the opportunity to speak with you today, and I look forward to answering your questions.
Mr. Heaphy, thank you for your opening statement, and we'll turn next to Ms. Doyle.
Good morning, Chairman Casey, Ranking Member Scott, and members of the Senate Special Committee on Aging. My name is Jane Doyle. I've lived in Bartonsville, Pennsylvania for the past 32 years. I have 2 children and 3 grandchildren living in the suburbs of Atlanta and Boston. I am honored to have this opportunity to testify to help make positive change towards better health care for everyone. I've experienced for myself and my family several different kinds of dual eligibility when I first was diagnosed with multiple sclerosis. I applied for Social Security disability, so I also qualified for Medicare. I still was able to work part-time, and I also accessed Medicaid through a special program. It allows people, excuse me, it allows people to work and still earn higher incomes, but otherwise qualify for Medicaid to pay premiums for the Medicaid benefits. It was a relief to have affordable insurance that covered out-of-pocket costs, and I found it quite purposeful to continue to work. Since 2017, due to further medical circumstances, I have been unable to work. I qualify for regular Medicaid. In 2020, Pennsylvania required Medicaid through managed health care. From the 8 doctors I see, I don't believe any of them are enrolled in the new system. So far, I've been fairly lucky. Most of my doctors have continued to see me, but they must write off the balances after Medicare. I recently received a balance bill from a new doctor who may not have even been aware that they weren't permitted to balance bill because of Medicaid. My doctors say that the new system is complicated and the rules are different across 3 different networks. I also worry that since many doctors don't take the managed care and these programs try to cut costs, the quality of care I receive suffers. During the pandemic, I had 3 operations, one which resulted in irreversible nerve damage. This resulted in me needing neurosurgery, and I had to travel 100 miles to Philadelphia to get that care. My mother is also dually eligible. She is enrolled in Medicare and began to need more help. She needed the kind of long-term care that Medicare doesn't cover. For some time, she paid for home health care out of pocket, costing around $7,000 a month. But for 24 years as a widow, her money was running out at 87 years of age. Thankfully, in Pennsylvania, Medicaid has a special program known as waiver. This provides home care. Our family viewed this as a great alternative to a nursing home setting for our mother. But to qualify, someone must first apply for Medicaid and then apply for waiver. The process is very long and difficult. It involves several applications, documentation from both Medicaid and doctors, choosing a provider to oversee your case, and finding a participating home health care agency with enough staff to meet our mom's needs. Eventually, we didn't have enough money to pay for one more day. I was fortunate to have stumbled across the Pennsylvania Health Law Project. They helped to expedite my mother's case. As you can imagine, the stress of not knowing how we were going to care for our mother was insurmountable. I've talked about the trouble my mother faced becoming dually eligible, the challenges I experienced as a dually eligible person. I'd like to tell you what would happen if I stopped becoming dually eligible. If I lose Medicaid, I would not be able to buy Medigap insurance to cover out-of-pocket costs because I have a pre-existing condition. For those of us with a pre-existing condition, Medigap is allowed to deny your insurance if you have Medicaid when you first sign on for Medicare. As a result, I'm stuck. I can't increase my income or savings because I will no longer have Medicare since I will no longer have Medicaid and I won't be able to buy Medigap. I would face much higher costs with having Medicare and no other insurance. This is a lot for one person to navigate. Fortunately, there are sources of help like the Pennsylvania Health Law Project and the kind folks at the Medicare Rights Center's National Helpline, which I've reached out to. I ask you today to do whatever you can to ease the burdens of people like me and my mother who have faced challenges. While these programs are important, they are not easy to use. To make these programs actually work, it needs to be much easier for people like myself and my mother to enroll and find the care. Thank you again for the opportunity to speak with you today. I look forward to answering your questions.
Well, Ms. Doyle, thanks very much. Appreciate your testimony. Now we'll move to questions, and I'll actually start with Jane Doyle for the first question. Jane, I wanted to again thank you for your testimony. These stories that are shared by you and other witnesses help all of us when we're trying to formulate policy, especially on complex issues like health care, and in this case, the challenges that dual eligible Americans face with regard to Medicare and Medicaid. In your testimony, you talked about your mother receiving long-term care at home. You stated that your family, quote, viewed this as a great alternative to a nursing home for our mother, as it would allow her to stay independent and involved with us, unquote. It's so important for Americans to be able to receive care in the setting that they prefer. Every person should have the option to stay close and stay connected to family if that's their choice. Can you tell us more about why home and community-based services were so important both to you and your mother and, of course, your family?
Well, in our particular situation, it was my mother's personal choice, and we wanted to honor that. Although my mom was college educated, my mom was a homemaker, and she wasn't really accustomed to a lot of outside socializing, and her home was her life. But the second piece to that question, in short, the quality of the care that we receive from both home care and the family pitching in was far better than what we had experienced in short stints in rehabs following hospitalizations. Nursing homes that provide rehabilitation were grossly understaffed even prior to the pandemic. And I can assure you from a recent hospital visit that understaffage is even worse. It's hard to leave your loved one and go home at night not knowing if someone's going to reach for that, if they're going to answer your loved one's call bell or simply place a cup of water within their reach.
My second question, I'll move to Dr. Figueroa. In your testimony, you told us about your experience not only as a researcher, but also as a provider for people who have both Medicare and Medicaid. Your testimony spoke to the importance of having various options for people when it comes to integrated care models. One of the models you mentioned is the PACE program, or as I mentioned earlier, the LIFE program in Pennsylvania. We have 7,000 Pennsylvanians that rely on PACE for their care, many of whom would otherwise be receiving care in a nursing home. Hundreds of thousands of others with Medicare and Medicaid in Pennsylvania. There are, I should say, hundreds of thousands of others with Medicare and Medicaid that may not live near a PACE program. and may not know that it is an option available to them. As I mentioned, Ranking Member Scott and I have introduced the PACE Expanded Act to reduce barriers to access and availability of PACE programs. Could you share with the committee how expanding a program like PACE might be better able to support individuals with both Medicare and Medicaid?
Thank you, Chairman Casey. Yes, I can. So the PACE program, as you mentioned, is a program that provides all healthcare services for older adults who would otherwise be in a nursing home. And the primary objective of the PACE program is to keep patients at home as safely as possible for as long as possible. And the key to the PACE programs are three things. One is that they're fully integrated financially. Two is that they have the multidisciplinary team, as Ranking Member Scott mentioned, the one-stop shop that includes nurses, doctors, therapists, social workers, case managers, all with one common goal, that they are fully accountable for the care of the patient across the entire care pathway. And then number three is that they maximize, again, what matters most to patients is keeping them at home in their communities with their loved ones. So some of the examples that they do a really good job on is that every time someone joins a PACE program, they give them they do really comprehensive patient assessments, full review of all of their medical needs. They get into communication with all prior physicians that have taken care of the person. And then they try to ascertain what really matters to the patient. What values do they really appreciate and what they want to really preserve. The second thing is that they create a plan that is unique to each individual patient based on those values. The third thing is that they then coordinate all of the care, as I mentioned, and it's usually in sort of an adult daycare type program where the multidisciplinary team operates. And then they often are always communicating with family members. And so I think expanding the PACE program is a good option, especially in areas where there are no integrated care models. We can think about ways of expanding the program. For example, one, you can scale existing PACE programs by increasing current capacity of existing PACE sites. The second thing you can do is you can think about spreading the PACE program, which in order to do so, you need to offer incentives to other areas and states where there are no integrated care programs or there's no experience among the local healthcare providers in participating in a PACE program. As you might have mentioned, there is a big challenge for the healthcare workforce to actually be certified to deliver PACE type care or nursing home care. And so that's an important challenge that needs to be overcome. And then the last thing you can think about is changing the scope of the program, which means expanding to other patient populations who do not currently qualify. So for example, I'd be really interested in seeing if the PACE program model would be beneficial for younger people with disabilities or younger people with serious mental illness. I think that might be potential avenues of exploration. Thank you.
Doctor, thank you very much. I'll turn to Ranking Member Scott.
Thank you, Mr. Chairman. As you would imagine, having the chairman on your left and your former chairwoman on your right, the best I could do is defer to her first, and then I will continue with my questions when it's my turn.
First of all, thank you, Senator Scott. You're always so gracious to me, and I very much appreciate it. And I want to thank you both for holding this very important hearing. Dr. Figueroa, I want to start with you. As we've learned today, listening to the testimony, and we know from our own experiences doing casework in our state offices, the dual eligible population is extremely diverse. Many people think of it as, to use just three common words, as old, poor, and sick. But that really does not capture the diversity of those who are in the dual eligible population. For example, a dual eligible might be an 80-year-old woman who requires assisted living services and has spent her remaining income on medical expenses. It could be a middle-aged woman with diabetes and pulmonary disease who requires a variety of specialists. It could be a young person with disabilities who lives at home and requires assistance with the activities of daily living. Moreover, some dual eligible people are not actually costly, but the minority makes the duals overall one of the most expensive groups for both Medicare and Medicaid. So my point is that what is driving the cost is different for each subpopulation. As we seek reforms to improve the care and lower costs where possible, how should we evaluate policies that might better integrate care, knowing that there's not one way? Could you give us some guidance on that?
Thank you, Senator Collins. Yes, I think you bring up a great point. And we should not expect, given the diversity of the population you just described, we should not expect that one strategy will work for everyone. A strategy that might work in urban areas might not work in rural areas. And so what we need is we need better data to understand what works for what specific populations. And in order to get to that level of understanding, we must do a better job at making the care, how we care, and the different programs and the different plans that care for dual eligible patients. We need to understand their effectiveness. We need to understand how well they perform for these populations. We need to understand what patient experience is like. We need to ask more questions of patients to determine if they really think their care is meaningfully different under these programs. And at the moment, we often have very lagged data that does not help us make decisions today for how to improve care tomorrow. If you look at a lot of the evaluations out there, the evaluations are from like data in like 2012, 2013, 2014, and we're trying to make decisions in 2022. That is very challenging for us as clinicians to understand which care models to refer patients to, and I'm assuming for policymakers to figure out what policy solutions they should be implementing at the federal level and at the state level. And so if we can somehow make data better and more transparent, and also be able to drill down which programs work for the young duals with schizophrenia versus with the older, frail adult living in a nursing home, I think we can then adopt and expand the models that make more sense.
Thank you, Doctor. The second issue I want to touch on with you briefly is the challenges posed by the workforce issues that we're dealing with. There was a recent survey of long-term care facilities in Maine that found that 94% of Maine providers were experiencing a staffing shortage, and more than half of the respondents replied that their situation was at a crisis level. At the same time, we know that these interdisciplinary teams are an important component of integrating care for dual eligibles. So could you comment on how the workforce challenges affect our ability to adopt and scale integrated care models for dual eligibles? Is this an area that should be more of a focus for Congress?
Thank you, Senator. Yes, I agree that it should be an area of more focus of Congress. We, as you said, have staff shortages across the country. And I think the COVID pandemic really exposed that vulnerability in our healthcare system. For example, if you think of nursing homes had significant nursing staff shortages, and the nursing homes with those shortages were much more likely to be decimated with the by COVID-19. And so one thing that we can think about in terms of improving the workforce, one is we need to compensate the workforce in certain areas better. We need to provide appropriate living wages so that we have less turnover and we have more people, good people, wanting to work in the healthcare sector. Another thing to think about is we need to think about training a diverse workforce. We cannot expect to have doctors in all areas of the country caring for the majority of patients. In some areas, we need collaborations with doctors and other types of professionals. For example, you can think about expanding community health workers to fill certain needs, especially in low-income areas where shortages are a problem. And so what kind of policies can we do to promote, for example, more community health workers practicing across the country, working side by side with clinicians and other healthcare providers? One thing we can consider is how we pay for community health workers. And we should think about appropriately paying community health workers and not just them providing volunteer services because they care about the community and the people they live in their communities. And so those are things that I think Congress and states can consider.
Thank you. Thank you again, Senator Scott.
Thank you, Senator Collins. And I just want to acknowledge as well, as I said, we'll have senators coming in throughout the hearing. Senator Braun was with us, and we'll be joined by other senators very soon. But I want to turn to Ranking Member Scott for his questions.
Thank you, Mr. Chairman. Let me ask Ms. Medina. The Healthy Connections Prime demonstration was South Carolina's first major effort targeted towards improving care for dually eligible individuals. Ms. Medina, can you talk about the lessons learned during this demonstration project and how do you envision its future moving forward?
Thank you, Senator Scott. There's been great success here in South Carolina with our dual demonstration program. It really was here in South Carolina the first attempt at serving our duals both in the medical services and long-term care services together. Having said that, we are at a point in the program, it is a demonstration. And so we've been working with our partners over at the Centers for Medicare and Medicaid Services to figure out what are our next steps. I think there are definitely opportunities to figure out what really works best in the state and what we can take from the experience with Healthy Connections into whatever we decide to design for the future.
Thank you, ma'am. Let me ask you another question. I have just introduced legislation that would provide states with one-time grant resources to improve care for dually eligible beneficiaries. One possible use of this fund is for state Medicaid offices to expand their understanding of the Medicare program. Is this something that you think states would benefit from? And would other witnesses like to weigh in if they would think it's necessary?
For sure, I definitely think that when it comes to Medicaid agencies, obviously the focus is heavy on the Medicaid population, Medicaid experience, and that institutional knowledge that goes with it. As dual integration has become such a hot topic, agencies are really looking internally to better understand the Medicare rules and processes, especially those states that have chosen to participate in the dual demonstration program or that are managing their dual special needs plans in their states. So I definitely think there's an opportunity that we would welcome to further increase our institutional knowledge around Medicare so we can make the best decisions for our state.
Thank you. Any other panelists like to weigh in on the question as it relates to the benefits of one-time resources, one-time grant money going to states to help to bridge the gap in understanding and appreciating the complexities of the two programs? I'll continue with Ms. Medina.
Oh, sorry.
Go right
This
ahead.
is Dennis Heaphy, and my thought is if there's a potential opportunity for increasing capacity and competency of state Medicaid offices to collect data that better aligns Medicaid and Medicare information so that states can actually start developing a data collection system that actually works to understand that, I guess that's what I would say is it's better data collection systems. Thanks.
Thank you, sir, for your comments. With the balance of my time, I'd love to ask Ms. Medina one last question here. There's always a natural tension between the states and federal government about the amount of federal involvement in administering large programs like Medicare. I believe that states are the best laboratories for treating their own unique populations. Do you believe that you have the appropriate amount of flexibility to provide coverage to dually eligible individuals?
As a state Medicaid agency, we definitely have to navigate really complex authorities when we want to design programs that best fit our agencies and our population. So absolutely, there are definitely delays sometimes in new processes or new guidance that they issue, but we continue to work with them to figure out what are the best pathways that we should take, especially when it comes to the various options states have in how to implement their programs and the corresponding authorities.
Thank you. Mr. Chairman, with my last 30 seconds, as opposed to asking another question that someone will not have time to answer, I think I'd like to just point out the importance of both having experts and people who are actually dealing with the dual challenges of this complex system. Thinking about Dennis's comments as it relates to having to take his wheelchair a mile to a hospital to get care, or thinking about our other witness who has spoken so clearly about not only Jane Doyle, her situation, but her mother's situation. So there is something about hearing from experts who can help illuminate the necessity of direction, but it's also, I think, incredibly informative and important to hear from witnesses who understand the real life pain and challenges that come with a system built for them, but not really. And so I think having a good balance has been helpful for me today.
Very well said by the ranking member. Very complicated issues and very personal. We'll turn next to Senator Warnock, who is joining us virtually.
Thank you so very much, Mr. Chair. Medicaid is one of the most critical safety net programs in our country, and it was created to expand access to health care for low-income children, for families, and people with disabilities. Because the Affordable Care Act allowed states to expand Medicaid, there are more than 10 million Americans, 10 million, who qualify for Medicaid due to a disability. Many of these same individuals also have Medicare. There are currently more than 300,000 Georgians eligible for Medicaid due to a disability. However, that number would be higher if my home state of Georgia would finally expand Medicaid, expand this lifeline program to more low-income individuals who live in the coverage gap, 275,000 Georgians in the Medicaid coverage gap, 500,000 uninsured Georgians, 646,000 Georgians who would qualify for free and affordable health coverage if Georgia joined the other 38 states and the District of Columbia in expanding Medicaid. Mr. Heaphy, in your testimony, you highlighted that not every state has provided innovative ways to ensure people have access to healthcare services like yours has. Can you talk now about the implications of living in a state that has not expanded Medicaid for individuals with disabilities, and you are no longer eligible for the program?
I wouldn't be here testifying. I'd probably either be in a nursing home or isolated in my home, or not alive. And I'm not being hyperbolic about that. It's very challenging for anyone with a disability to be able to live even with Medicaid services, but without eligibility, it's even more devastating. I think something that needs to be considered too is work requirements. That for someone like me, I love working. The importance of working to me is just it's important to me, and the opportunity to work in Massachusetts is great. However, the requirement of a work requirement scares me because it would it disproportionately impacts folks with substance use disorder, folks with mental health diagnoses, folks who may not have may not be able to demonstrate the level of disability that's required to be eligible for Medicaid under under the under the Medicaid requirements. And so for me, access to Medicaid is the first step towards accessing health care. And the lack of ability to get Medicaid is really just it's a I don't want to, but it's really a human rights issue as well as a civil rights issue. Um, and so I would not be able to live in another state. And matter of fact, in Massachusetts, I live in Massachusetts. I've been because of the healthcare system here, I've been offered jobs in other states and not been able to take those jobs because of the lack of supports provided. In Massachusetts, I can actually increase the amount of money I make and still maintain my Medicaid benefits. And so the ability to maintain Medicaid benefits over time that supports my ability to work. And so I think what's important is really to look at how to incentivize the ability of people to get Medicaid and work at the same time without penalizing people who can't work. I don't know if that answered your question or not, but that's
No,
what came to mind as you were talking.
sure, it absolutely answers my question. And to your point, after just 10 months of Arkansas's Medicaid work requirement, for example, some 18,000 poor and disabled folks lost their health care coverage after just 10 months with this work requirement. I live in a state that has an expanded Medicaid. And what I'm hearing from you is that you might not be alive if you were just in the wrong state, in the wrong zip code. I happen to think that healthcare is a human right. And if it's a human right, it's not a human right in 38 states. It's a human right in all 50 states where we have an Affordable Care Act law that's been on the books for 10 years. Thank you so very much for your courage and for your witness today.
Thank you.
Thank you, Senator Warnock. I'll continue with my questions and may turn to the ranking member after that, and then I think we'll have Senator Gillibrand after that. I want to turn back to Jane Doyle. Jane, you highlighted how difficult it was to help your mother apply for and enroll in the care that she needs. In your testimony, you talked about, quote, several applications, unquote, and having to attach, quote, hundreds of documents, unquote. Hundreds. You also describe your own experience applying for Medicaid at different points in your life, while you had Medicare, while you were working and when you could no longer work. At various points, you turned to nonprofit organizations like the Pennsylvania Health Law Project and the Medicare Rights Center for help. I imagine there are so many people listening at home who can relate to your story. As Ranking Member Scott made reference to, it's so important to hear from people that are living through these challenges. Jane, are there things that you could have, or that could have made the application and enrollment process easier for you and easier for your mother to navigate?
Thank you, Senator. Well, it was a little more clear for basic Medicaid for myself, but for my mom it wasn't. In short, I think the answer would be to make the whole process quicker, but that might not be exactly realistic. A certain degree of prudence obviously certainly needs to ensure compliance of the programs. But I will say for what we call in Pennsylvania as nursing home level care Medicaid, the big issue I had was the $7,000 asset mark. And so with the $7,000 asset mark, for a person with very, very high needs, that money is spent very, very quickly. And First, as I mentioned in my testimony, you have to qualify for Medicaid, and not everyone is already qualified for Medicaid. And then you go on to the next application of waiver. So these dual applications can take 2 to 3 months. And as you can imagine, $7,000 when $7,000 a month is going out for high needs, that's not going to last you that duration. So possibly that limit may be able to be increased to allow people the time needed to get through the process, maybe one way. The other way, maybe integrating, we've talked a lot about that during this meeting, but possibly integrating that process of applying for Medicaid and waiver together, may make that more efficient. Also, in my case, this may be local, but it would really be great if they update, government and local government update their websites and make sure they have the correct forms online so that people can access those and that you can upload those documents that we mentioned earlier. That would be far easier than having to photocopy a book to get down to the county assistants with your process. The other thing that I'll talk about, there's a lot of programs for help to reach out to, but I myself found myself making numerous phone calls before I found the correct source. And I can't imagine that, elderly people with maybe fewer skills or a bit of confusion, I can't imagine how they might get through the process. I would suggest perhaps more awareness and designate maybe one agency that fields people to the right resource. That might be helpful. My first resource, which unfortunately was not all that helpful, was the local Office on Aging. I did not find them particularly resource knowledgeable, but I think elderly might tend to go there. That might be a good place to start for people to find out where they need to be guided for specific issues for this massive, massive system.
Jane, thanks very much, and thanks for giving us your perspective from a very practical, from the perspective you have, which is very practical. I'll turn to our Ranking Member Scott.
Thank you, Mr. Chairman. And I also note that some of the comments that we've heard during the hearing about the importance of understanding and appreciating the path back to work for Medicaid and some of the challenges that face, especially for folks in Dennis's situation. I think there's always going to be a carve-out or a second look at the concept of welfare to work. I do believe that Bill Clinton, President Clinton's approach to welfare to work in his 1992 campaign that he actually was able to pass through was overall good for the country and good for people, and frankly, something I completely support. I do believe that we should always take into consideration special exceptions when necessary, but the path forward certainly, I think, is a good one overall. Dr. Figueroa, may I ask you a question about the challenges that you find dually eligible beneficiaries facing when receiving care? I think the Chairman Casey did a really good job of really simplifying this web of challenges of paperwork and the streams of challenges that come along with those binders that you're trying to find your way through when you're looking for help in all the wrong places because the paperwork jigsaw puzzle seems to be missing a few pieces. But beyond that, can you talk about some of the other challenges that dually eligible beneficiaries face when receiving care?
Thank you, Ranking Member Scott. As you mentioned, the administrative web and complexity is a wall to access healthcare. It is a wall that people have to climb over to access healthcare. And as we mentioned, these are very vulnerable people living in poverty. Some people with limited health literacy, some people with limited computer proficiency, and that wall is insurmountable for some. And these are the people that need care the most. These are the people that want to be at home living with family and their friends. And these are the people that are unfortunately stuck behind this wall. And this wall prevents them from, for example, if they need medical equipment to be at home and they have to call 2 different insurance programs, they have to sometimes have to wait to be denied by the Medicare program before they can ask the Medicaid program, can you cover this medical equipment that my doctors and my therapists say that I need to be safe, so I don't have to, so I can get around my home safely, so I don't have to fall at my home. The 2 different programs sometimes as well in getting, payments for their hospital care and trying to figure out the sharing between, the 2 different programs. Also in terms of how long can they be in a nursing home and how many days is covered by the Medicare program before the Medicaid program kicks in. And so it is all a wall that complicates the lives of not just patients and families, but also to us, to the clinicians and the healthcare providers. And instead of us spending time taking care of the patients and improving their health, we're spending time on the phone trying to figure out how to get the care they need. And that's a problem in our country, and I think we need to fix it. And the way to do it is by integrating everything, creating one true program, having one pot of money where the people and the healthcare providers that are responsible for the patients can use to ensure that they can cover everything that the person needs.
Thank
And
you,
without
sir.
integration, it's very hard to do that.
Thank you very much. Ms. Medina, dual eligible program enrolls only a fraction of those who are eligible for these plans. How can states enroll more people in plans that work for them?
In South Carolina, I hope to approach this in 2 ways. First, by streamlining our programs. As I mentioned earlier, when you have so many options, it's hard for beneficiaries to really understand which direction to go. So if you offer them one really good program or just a couple, I think that makes things easier for them. I also hope here in South Carolina to bolster our customer service approach. I think that the state Medicaid agencies are truly a safety net for beneficiaries and providers, and we have a responsibility to be available to them when they encounter the roadblocks that we've discussed today.
Thank you very much. Mr. Chairman?
Ranking Member Scott, thank you very much. I want to move to a question for Mr. Heaphy regarding home and community-based services. I mentioned earlier we've got legislation to provide more of those opportunities, and you, Mr. Heaphy, had mentioned in your testimony the importance of those services in keeping you independent and giving you a high quality of life. I note on page 3 of your written testimony, you said, quote, "What I need most are home and community-based services and supports," unquote. And you later noted that your personal care attendant often participates in conversations with you and members of your care team. Your testimony spoke to the importance of making sure that these services are available to all who are eligible and the inequality and availability of these services across states. So that's why we've introduced the Better Care, Better Jobs Act. From your perspective, Mr. Heaphy, how would a robust investment in these services impact the lives of people with Medicare and Medicaid across the country?
There's so many things that come to my mind, but first it's to recognize HCBS as a means of offsetting institutional bias for folks who have Medicaid and Medicare. Myself, I'm someone who's eligible, nursing home eligible, and for me, I would be in a nursing home, as I've said before, if I did not have the HCBS services I receive. And I think it's important that when that that people be able to remain in the community with folks they love, people in their family, rather than being isolated in an institution and away from the folks who provide the supports. I also think it's important that states maintain a commitment to allowing people to remain in the least restrictive setting possible. There's mounting evidence that shows increased choice, satisfaction, and personal outcome achievements are associated with home and residential settings of smaller size. People with disabilities living in settings in smaller settings are also more likely to achieve positive outcomes and to experience improved personal support related quality of life and than individuals living in larger settings. Uh, I think I think probably the most important aspect of HCBS to consider is that it's important to take a lifespan approach and recognize that the needs of children and families are very different than folks who are adults or older folks, and that in if HCBS is solely determined on medical necessity, it doesn't take into consideration the developmental milestones of kids with disabilities. I think for those of us who learned how to drive, have driver's license, and know how important that milestone was in our lives to be able to go independently and do things for ourselves. I think it's really also true of children with disabilities. They have an opportunity to have a wheelchair they can actually use, one that meets their needs in terms of meeting a milestone as opposed to just a medical necessity requirement is really important. So an expansion of understanding what determination of need is. I think it's also important that day habilitation services not be the default for folks with high LTSS needs, whether it be adults with developmental disabilities or mental health diagnoses. That the promise of integrated care is to really provide tailored HCBS services that really meet the person's needs and provide them the greatest opportunities to live in the community. And I've experienced that here myself, as a dual eligible. And if I if I but were not able to shape my LTS services, I think it would be in a very different situation. I guess I would also say this is really important is I alluded to my personal care attendants. They're so woefully underpaid and underappreciated. They're in the homes. They're doing work that nobody else wants to do. A lot of folks can't do the work, and yet the amount of money they make that is not there. My PCAs engage in what's considered to be nursing level activities. That includes changing my catheter, doing wound care, and assisting with my bowel program. And they're doing all this work and not receiving the money that they really need to live in the community. I get an example would be in Massachusetts, which is very generous. PCAs make over $17 an hour. However, a living wage in Boston is actually over $19 an hour, and for someone who has a child, that's over $39 an hour for a person to actually have a living wage. And so as HCBS is being thought and determined that the wages of folks doing this direct community work needs to be considered. And the last thing I would say is that it's really important that the consumer-driven model be central to HCBS. Because I'm a consumer employer, and my PCAs work for me and not an agency. Uh, I am able to direct my care to them and able to really define my schedule. I'm able to travel for work. I'm able to do things in the community that I would not be able to do in an agency. There's definitely a place for the agency model. However, for folks like myself who really need that flexibility to engage in the community, we need that opportunity. That need the opportunity to live in live in the community using these PCAs. And with COVID, in particular, if not for my personal care attendants coming into my home, I would have been devastated. And yet, it's because the relationship my PCAs and I have with each other, that they were dedicated and came to my home during COVID, despite putting themselves at risk. And so I can't say more about making sure that these folks get reimbursed at an adequate rates.
Well, Mr. Heaphy, thanks so much for your personal testimony based upon your own experience and being a voice for those workers who are among the folks that we hope to be helping with some investments in home and community-based services that are not available today.
And if
And
I could just add one more thing, Senator, I'm sorry, that's,
if just quickly, because I want to turn to the ranking member.
sure. And that, we need, I think it would be really helpful to institute like the national core indicators across the
Mhm.
country, and also HCBS caps, because this will give us a better sense of the quality and access to HCBS and the outcomes. That's the other thing I would say is having that national snapshot of how states are doing and performing, and where HCBS is going is critical.
Well, thanks very much. And we're waiting for some other senators who have had to juggle things. We hope they arrive. But in the interim, Ranking Member Scott, do you have additional
Mr.
questions?
Chairman, I've just joined if you want to call on
Oh,
me.
Senator Gillibrand,
Yeah.
right on the money.
Yeah. Thank you. I had competing hearings. A quick question for the whole panel. How should we be thinking about incorporating community health workers into integrated Medicare Medicaid plans? And do you have any examples where this is already being done, particularly when it comes to navigator and ombudsman services?
I can go ahead and start if you don't mind. Thank you, Senator Gillibrand. So I think community health care workers play an important role as the liaison, as you know, between the healthcare system, social service organizations, and the patients in their community. And they're generally well-trusted people who understand the values of their community as well. So it's a potential workforce that we should tap into. Especially in areas where there's limited workforce and limited healthcare infrastructure. And the key, though, for a successful community health worker relationship with the patient is that they must be integrated with the care team. If they're only in the community and not necessarily integrated with the care team, it's not going to be a successful relationship, unfortunately. And so really trying to promote integration is key. I do know of one example in Massachusetts, for example, that through under the 1115 demonstration, Massachusetts made all of their Medicaid patients participated in ACOs. And in that, there was a lot of funds that went into hiring community health workers, training community health workers, operating in areas, for example, in Western Massachusetts, where there's not as much providers as Eastern Massachusetts. To date, about 1 million people are in these Medicaid ACOs, and the evidence to date in a recent survey we showed is that providers and ACOs think that community health workers are operating well with social service organizations and improving patient experience.
Thank you, Mr. Chairman.
Thank you, Senator Gillibrand. We're going to move to our closing statements at this time. I want to thank, of course, Ranking Member Scott for hosting this hearing with me and the work that he's done on the legislation that we've introduced. So I want to thank him for that work. I also want to thank our witnesses for their invaluable input and, as we noted earlier, their personal experiences. As we heard today, people with Medicare and Medicaid face many challenges in navigating the healthcare system generally, but in particular, these challenges that our witnesses outlined today. This challenge that they face will impact their overall health and their quality of life. So we have work to do. The people that testified today, whether it was Jane or Dennis or others who shared their stories, these stories help us in Congress to formulate policy and propose legislation to make these programs work better. The healthcare system, their healthcare system, should provide support for them rather than adding yet another headache and so much confusion. Jane, for example, Jane Doyle, for example, should not have to worry about getting a surprise bill in the mail after a doctor visit, wondering if she's on the hook for that bill or not. Dennis shouldn't have to go to the emergency room because he cannot get a hold of his plan's care team, who were supposed to be there to help him. We need to make sure that the care delivery models available to people with Medicare and Medicaid meet their needs and meet their preferences. That's why we must pass the PACE Expanded Act that Senator Scott and I have introduced to increase the availability of these programs. And it's why we should make a permanent investment in home and community-based services to help seniors and people with disabilities remain with their families in their communities. So we're grateful for the testimony of our witnesses, and now I'll turn to Ranking Member Scott for his closing statement.
Thank you, Mr. Chairman, for holding, once again, a really important hearing for so many Americans who are looking for more information and, frankly, more reasons to be hopeful as they deal with declining health and other challenges that too often come with aging. Today, we learned about the challenges of caring for dual eligibles. There are numerous gaps in policy and knowledge that contribute to these challenges. As the son of a caregiver, my mother, as I've said a number of times, has been a nurse's assistant for her entire career. Last week, I was visiting her at the hospital, and it is this week is her 49th year at the hospital, and she loves her patients. She loves what she does because she really loves the thought of making a difference. And in today's world, I think we need more people dedicated to a mission, whatever that mission is for you. We should all be thankful that people have the mission of providing care for those who cannot care for themselves. The Supporting Care for Dually Eligible Individuals Act will help fill some of those gaps. This legislation will help states provide the care this population so desperately need, and the testimonies today only reinforce, if not amplifies, the importance of that truth. I'll make two other points that I think is really important. Number one, I think Dennis and so many others have done a really good job of helping us to understand and appreciate the importance of home health care. While you can sometimes get in a senior facility, or as my mother working in a hospital, so many people prefer their care to be given in the environment that is best for them, and that environment so often is at home. I think all that we can do to help people receive the care they need in the place of their preference is really an important part of health, because peace of mind and health are so often synonymous. Not only is there the mental health component, but there's a physical health being delivered in your home where you're comfortable, where you know where things are, cannot be overstated, to be honest with you. And I think that very often that providing home health care is actually better overall in a system that has limited resources. And it does not seem that we do, but when we're spending over $550 billion or so for Medicare, and nearly $400 billion for Medicaid, and over $400 billion for veterans benefits as well, we run into the challenge of limited resources. I think we can take our resources further by focusing on a delivery system that is so often at home. The final comment I would make is that as we think through the unbelievable challenges of the pandemic, one of the more important points is the delivery system of virtual healthcare. To have patients, as we spoke about today, being able to see their doctors from their homes when possible, really helpful. And I hope we continue as a nation to move in the direction of providing virtual healthcare as a priority and as a priority delivery system, because I believe that not only will it help us take care of our patients, it will help us spend the limited pot of resources in the most effective way possible, providing amazing assistance and care for those who desperately need it. Thank you again, Mr. Chairman, for this hearing, and I look forward to the next one.
Ranking Member Scott, thanks very much. I want to thank you again and thank all the witnesses again for their expertise and their time today. If any senators have additional questions for the witnesses or statements to be added, The hearing record will be kept open for 7 days until next Thursday, February 17. Thank you all for participating. We are adjourned.